Welcome to the NEI podcast. In this episode, we present a series of extended Q&A sessions recorded at the 2025 NEI Fall Congress in Colorado Springs, Colorado. Faculty members who presented at the Congress will respond to unanswered questions from selected presentations. Stay tuned for insightful discussions.
Hi there, I'm Dr. Brittany Albright, and I'm an addiction psychiatrist, and I am ready to answer your questions about my joint presentations with my good friend, Dr. Hara, a discussion of substance, supporting meaningful improvements in the lives of patients struggling with substance use disorders. Let's begin, and I am thrilled to see all the questions that you guys asked. It's very clear that you're also passionate about this topic as I am. The most requested question was, can you repeat the wellness website that I suggested during the talk? Absolutely. It's Wild5 Wellness, which is www.wild5wellness.com. It's a free 30-day wellness program, not only evidence-based for our patients, but for all of us as clinicians. It's actually been researched extensively as a way to prevent burnout. And the 5 components are sleep, exercise, nutrition, social connectedness, and mindfulness. It was created by doctors Sandra Jan and Rakesh Jan. And again, it's completely free. Patients can log their data on this website. If they're like me and they like a physical booklet, I know I just got mine on Amazon, and it's less than $5. Basically, you pay for the cost of shipping, and it's been a tremendous asset, not only to me personally in my own wellness journey, but also to my patients. Great addition to any treatment program for substance use disorders. The second question that came up was, how do I approach a patient with opioid use disorder who is always asking for higher doses of buprenorphine, especially when life gets stressful due to return of cravings? I try to never go over a total daily 24-hour dose of 24 milligrams of buprenorphine naloxone. They've done a lot of research, and anything above that doesn't necessarily convey additional treatment benefits. In fact, it likely just conveys additional side effects, which most common: constipation, delayed gastric emptying, nausea, sexual side effects as well, blunted affect. The vast majority of my patients over the years have ended up on 16 milligrams sublingually daily. And I would say if I had a patient who kept wanting to push that, I would try to explore why, and also to assess what treatment resources are they utilizing. Are they utilizing peer group supports? Are they attending psychotherapy? Are they practicing their wellness exercises? And if not, I'm going to try to beef those up instead of just increasing the buprenorphine. Also, I always want to assess, is there a medical condition going on? Are they struggling with chronic pain? Are they struggling with depression, with an anxiety disorder, with bipolar disorder? And I'm going to target my treatment towards their underlying comorbidity instead of just, again, increasing a medication that's a controlled substance. Now, that being said, there are patients that may be more rapid metabolizers that might benefit from a higher dose, but that's a more selective population. Another idea, too, is you could consider switching them to one of the 2 long-acting buprenorphine injectable medications, and they may just have better, more consistent plasma levels of buprenorphine if it's in the injectable form versus sublingual. One point I do want to bring up is I have had patients over the years on different generic versions of buprenorphine, especially the buprenorphine tablets, where they have reported that it's not as effective. And so that's another option, is switching them to a different generic buprenorphine product. Sometimes I have more success depending on the generic brand. Another question was, what treatments are you using for methamphetamine use disorder? Are you using Vivitrol? Are you using lisdexamfetamine? Which Vivitrol is the name brand of naltrexone long-acting injectable. It's a month-long treatment that's FDA approved for alcohol use disorder and opioid use disorder. So unfortunately, there are no FDA-approved treatments for methamphetamine use disorder, and I'm hesitant to use medications for that indication because there can be risks. I would say most commonly I use bupropion. However, there is a risk of seizures, of elevated blood pressure. And so with methamphetamine use disorder in particular, I really deploy psychotherapy. I try to understand the underlying reasons as to why that they are abusing a stimulant. Often these patients have untreated bipolar disorder, untreated ADHD. They may have untreated obstructive sleep apnea causing excessive daytime fatigue, and I will treat their underlying psychiatric condition. Now, stimulants are not necessarily contraindicated in this population. There are patients with comorbid ADHD and stimulant use disorder where I will continue to keep them on ADHD medications. I'm just very careful, and I might be more likely to use a patch. They actually make ADHD medications in patches. There's a methylphenidate one, and then there's also an amphetamine patch, and I found those to be more successful in my harm reduction efforts to treat ADHD and ensure that I'm not worsening their stimulant use disorder. But again, be cautious with that. There's a risk of seizures, of hypertension. The next question, can you give us some insight on contributors of false positive alcohol in urine or serum drug screens? This can certainly be an issue, especially in the post-COVID era where we use a lot of hand sanitizer. And I often don't order alcohol levels in drug screens or as part of my urine screens. If I want to measure alcohol use, I'm going to order what's called a percent CDT or a PEth test. That actually gives us a better gauge as to what their alcohol use has been like over the past few months and not just some transient lab. And so if you do see a positive alcohol screen and you're concerned, you may want to consider ordering one of those two serum labs to get a better picture as to if they're drinking and if so, approximately how much. I also am fairly cautious about ordering urine drug screens in general. I try to really ally with my patients and have such a strong rapport that they feel comfortable disclosing to me their substance use. I think that urine drug screens can be very helpful, especially in early recovery or if you're prescribing controlled medications and you're concerned about an interaction between a substance of abuse and a medication you're prescribing. But ultimately, they can feel punitive at times to patients, and I like to rely on our rapport and trust. And when they do experience a relapse, that they feel comfortable approaching me to tell me about their relapse. Next question. I have a patient that I put on 50 milligrams of naltrexone for alcohol use disorder. He started drinking fewer days, but many more alcoholic beverages per day. Has the effect of dulling the intoxication caused him to drink more alcohol to experience the same intoxication? What a fascinating question that is. And actually, that makes a lot of sense. I've certainly had patients that unfortunately will discontinue their naltrexone because it is effective and it blunts the pleasurable effects of alcohol and, of course, opioids. And therefore, they don't like taking it if they plan on drinking because they have to drink more alcohol to achieve the same physiological response that they're looking for. And this is, again, why the long-acting injectable of naltrexone can be great because it helps to prevent patients from choosing to forgo their medication that day so that they can drink. But that question is wonderful, and I would state yes. I think that he likely is having more drinks on those days to experience the same psychological effect. And that may be a patient where moderate alcohol intake isn't going to work for him, and that patient may need to practice complete abstinence, which is quite a challenge for a lot of our patients. But we have to meet them where they're at. We have to use motivational interviewing and not pressure them into complete sobriety if that's not something that they're ready for. The next question, can the same at-home drug regimen for opioid withdrawal be used for kratom withdrawal? Also a fantastic question because kratom is becoming a substance that's more and more regularly abused in this country, as it is very readily accessible in most states. It's not illegal yet in most states. And pharmacologically, it mimics a lot of the effects of opioids and can be very dangerous. And patients can have the same effects as opioids, such as increased cravings, similar opioid withdrawal symptoms, and it can be very uncomfortable. Therefore, there's nothing FDA approved to treat kratom withdrawal or kratom use disorder. However, there's a lot of research on the use of buprenorphine in this population, and that's what I've used clinically in the past as well. Sometimes I can get away with a lower dose of buprenorphine, and I would practice the same induction that I would with traditional opioids of making sure that a patient is in active withdrawal, ideally at least 12 to 24 hours after their last kratom use or after their last opioid use, and try with 2 to 4 milligrams sublingually of buprenorphine first, wait a few hours, and if they're still having withdrawal symptoms, cravings, then they can take another 2 to 4 milligrams sublingually until they find a dose that eradicates those withdrawal symptoms and cravings. Additionally, you could also use clonidine PO to help with the withdrawal symptoms and the discomfort there. I often prescribe ondansetron for nausea associated with opioid and kratom withdrawal. Also something to alleviate the GI distress. Often I use Bentyl for the GI distress as well in opioid withdrawal or kratom withdrawal. Next question, is a substance use disorder or alcohol use disorder actually genetically influenced, or is it more learned behavior? It's both, and this is where I think epigenetics plays a tremendous role, where around 50%, especially for alcohol use disorders, it is heritable. There's, of course, not one isolated gene that we know of, but if a child has this genetic predisposition and they're raised in an environment with a lot of adverse childhood experiences, if they don't have great parental role models or any adult role models for that matter, then epigenetics can come into play and really turn on those genes. Also, so much of it depends on the sociocultural aspects of the environment in which we're raised. For example, do your loved ones lean on substances when they're feeling strong emotions? Or is it avoided due to, for example, religious reasons? That's certainly going to influence people's perceptions of using substance. Peer groups play a tremendous role. Are you part of a friend group in high school that frequently uses cannabinoids or alcohol? Or are you part of a friend group that focuses on studying, on participating in sports activities? And so that's why with children, it's so important that they have loving adult role models, that they're engaged in activities, and that they have a safe, supportive environment, not only at home, but at school. And our kids' peer groups are extremely important. The next question, how do you help patients with depression and or PTSD who also struggle with alcohol use disorder and don't want you to bring up their alcohol use? I absolutely love this question because this is one of the main reasons why I decided to specialize in substance use disorder, is because it plagues so many of our patients with major depressive disorder and with anxiety disorders. And when it comes to this, I utilize motivational interviewing. I ask open-ended questions. I talk about what's bothering them. And I'll ask in general, tell me about your relationship with substances. How does that fit into your life? I always try to ask permission too before I bring up a challenging topic such as substances. Do you mind if we talk about your alcohol use today? I want to make sure I have a full picture of your life and what you're putting into your body. It's really important to me, and I'm not here to judge you. I'm here to support you and to help you. And also, I want to keep you safe and healthy from a medical perspective. And a lot of the medications that we use for major depression and for post-traumatic stress disorder can be impacted by other substances that we put in our bodies, not just alcohol, but even supplements, even the foods that we eat, even tobacco, nicotine, smoking. and just make it a safe environment. And if they say, I don't want to discuss it, I say, I honor that. And let's pick up this conversation at a time where it feels more comfortable and more accessible to you. It's understandable, given the burden of the symptoms that you've experienced, why alcohol could feel like a helpful coping mechanism. Often, especially with, I think about my veterans that I've treated over the years with post-traumatic stress disorder. I just straight up tell them, I completely understand why you rely on alcohol and or drugs given what you've been through. It's unimaginable what you have had to endure. No human should have to endure. Can we work together to find options that in the long term are going to be healthier for your physical health and also be more protective of these relationships in your life that you hold so dear? And that's how I approach those subjects. Also, be prepared that your patients are going to tell you no, or they may not tell the truth. I know when I reflect on times where I've been to my own doctor over the years, and I may have had more than a couple of drinks at a time, I personally feel shame admitting that sometimes. And sometimes I'll use myself in very limited self-disclosure to help my patients. Like, oh, these are really tough questions. I know I've been tempted to answer them incorrectly as well. I'm not out to get you. I'm not out to judge you. We're here to partner together to make you feel well. And in order to accomplish that, I need to know what you're taking and how it's impacting your life too. Next question. For someone who is a licensed professional who doesn't meet criteria for alcohol use disorder and wants to cut down but fears stigma and potential licensing concerns, how do you discuss these treatment concerns? This is a fantastic question, and it's because it's really been on my mind in my own clinical practice. For alcohol use disorder, as long as there's no moderate to severe liver concerns, and after consulting with a GI clinician, and if they determine that it's not safe to start naltrexone, I won't. But otherwise, I really like to use naltrexone for alcohol use disorder, especially among fellow healthcare clinicians, because we experience high rates of burnout, and it's very common for us as healthcare workers to turn to alcohol either to help fall asleep, which unfortunately alcohol actually has the opposite effect and really disrupts sleep architecture, or to alleviate stress. And it does work in the moment, right? I mean, there's a reason why alcohol is so frequently consumed in this country, but we know about the long-term health consequences. And we also know how we feel the next day. And I've had many healthcare professionals, many psychotherapists over the years that actually do meet criteria for alcohol use disorder. And I'm not the police. My main objective is to get them well. I do assess if it's hindering their clinical performance. And if it is, we discuss the option of our state's recovering professionals program, if that feels appropriate. But at the end of the day, you have to check with your state to see if you are a mandated reporter. Luckily, in South Carolina, that's not something I have to do, especially for nursing colleagues and for therapy colleagues where I have no say in their medical or licensing board. The great news with naltrexone in particular is it has many uses. For example, naltrexone is FDA approved for weight loss in the form, the brand name is Contrave. It has bupropion and naltrexone in it. I also see naltrexone used in lower doses off-label frequently for conditions such as chronic pain, as hair pulling conditions. And so there's no way necessarily that a licensing board could state, oh, this person is on this medication, naltrexone, specifically for alcohol use disorder. We need to investigate this. I've had many physicians and other healthcare workers successfully be on naltrexone with no problems. I've put many actually pilots on it too, although pilots can be a more challenging subset because often their licensing requirements are much stricter. Now, one issue I'm dealing with currently in South Carolina is that they have not historically allowed physicians with opioid use disorder to be on buprenorphine, which I think is extremely unethical, and it goes against the evidence. First of all, there's not any great evidence to support that being on low therapeutic doses of buprenorphine hinders performance. Secondly, I had a physician almost die of an opioid overdose because he could not be on a medication like buprenorphine. Therefore, my argument is that it's actually safer for clinicians with opioid use disorder in remission to be on a medication such as buprenorphine because we know that it helps with relapse prevention, it helps with cravings, it helps our physicians, our nurses, our colleagues to remain in remission from this disorder, and they deserve the same level of treatment as anyone else in the general population. And so that's actually something that I'm actively working on with this patient. He should not have to wean off buprenorphine just because of an outdated licensing requirement. And so make sure you're counseling your healthcare worker patients, your pilots, also other professionals, first responders too, about the potential implications and that they should look into this prior to starting something like buprenorphine, sadly, and also get involved on a state and political level to ensure that your patients can access the treatments that will keep them safe and healthy and also keep the general population safe and healthy too. Next question. It sounds like you would not recommend prescribing gabapentin to treat cannabis use disorder, which they're defining as daily users of greater than 10 years, and this individual treats a veteran population greater than 60 years. Cannabis use disorder is a major challenge, I think, for all of us. It's become so highly used in nearly every state and so highly unregulated, and it's not the same marijuana as many of our patients experienced in the 60s and 70s, for example. And so my main strategy with cannabis use disorder, it starts with harm reduction of let's try to focus on if this is something that you're unwilling to change. And again, I'm using motivational interviewing. That's not necessarily what I would state to them. How can we make this safer for you? What sources are you getting this product from? Is it from regulated dispensaries? Is it from the streets? I know I've had many patients over the years that have been positive for many other substance of abuse that thought they were using cannabis buds, but it turns out their drug screen was positive for opioids, for benzodiazepines, for methamphetamine. And so we really have to do a lot of harm reduction with these patients. Also, can we work on dose reduction? Would that work? I love to discuss with my patients. Tell me what you like about this substance. Tell me what you're struggling with. What are your goals with this substance? And just be very non-judgmental in the process. Pharmacologically, though, there are some limited clinical trials that looked at gabapentin, for example. None of the data that I'm especially impressed by, and we know that gabapentin conveys risk too. For example, weight gain. It can cause sedation. Therefore, if the patient has an underlying condition such as neuropathy, chronic pain, I might actually be more apt to try gabapentin in that patient if I'm using it for an on-label reason. But otherwise, I've seen many patients over the years abuse gabapentin as well, and that's why I try to avoid it in particular. Next question. Have you used a camprosate for patient continued alcohol use despite being on LAI naltrexone? Yes. I think it's important that we try each FDA-approved medication that if a patient has not had success with the first treatment or with the second treatment, let's start with the FDA-approved medications first. And there may be many patients where a camprosate works for them, but for example, naltrexone did not. Again, a camprosate is tricky because patients have to take it 3 times a day, which is a challenge for many of them. And I also want to assess, well, if the naltrexone LAI is not working, again, do they have the psychosocial supports in place? Do they have psychotherapy in place? Have they gotten rid of all the alcohol at their home? Are they in a working environment that's not conducive to their sobriety? Example, I live in Charleston, South Carolina. A lot of my patients are part of the food and beverage community, and it's really, really challenging to stay sober in that environment. And so many patients, after years of struggling with relapses and successes, sobriety, we've had to work towards finding a different career where they're not surrounded by alcohol. Next question. There's little information that I've been able to find on inhalant abuse. I have a patient, but he has relapsed 2 to 3 times annually. We have a good rapport and he refuses to see an addiction specialist. Do you have any suggestions for cravings? Well, first, whoever asked this question, I applaud you. That is so amazing that you've made your patient feel so safe, that your patient continues to return to you despite these relapses. Inhalant abuse is really tough, and part of it is we just have not had large clinical trials to really discover what could work in that patient population. Unfortunately, I'm not aware of any one medication that's been found to be effective for that condition, and that's when I lean on really treating the underlying comorbidities that are contributing to the patient wanting to use substances of abuse, such as inhalants. I find often if we can very aggressively treat the underlying depression, underlying bipolar disorder, schizophrenia, anxiety disorders, often that can help with that. One of the most common reasons I see in my practice, though, for my patients that continue to cycle through relapses and remission, it's really challenging psychosocial stressors, particularly domestic violence, actually, that patients can never get well. It doesn't matter what medications we give them for sobriety. If they're in an emotionally, physically, financially abusive situation, if they have housing insecurity, food insecurity, financial stressors, there's no medication that is going to take those stressors away. And so often I employ my social worker skills and try to help them get the resources that they need to mitigate all of the stressors in their lives. And I really empathize with these patients about what they're going through. And it sounds like you do a fabulous job too, as evidenced by that patient not wanting to see any other treater, but wanting to continue to see you. I also admit, even though I am board certified in addiction psychiatry, I can't be everything to all patients. And there have been many, many patients over the years where I say, I can't provide the level of care that you need. I care about you so much that I want you to look into these programs, these resources that can be in addition to our care. For example, your patient that continues to relapse on inhalants, they may benefit from a partial hospitalization program or an outpatient day program. They may benefit from a weekly or even daily peer-led support group. That sometimes we can't provide everything our patient needs, but the resources are out there in the community. But just continue to encourage your patient that you're not going anywhere. It's just they may need some additional support right now because we don't have medications that can really treat the cravings or the reasons for the underlying stressors. Often I find too that my patients relapse due to poor coping skills, poor distress tolerance skills. And that's where psychotherapy is one of the most important and helpful components to really reteach our patients these skills that maybe they didn't learn or that these skills weren't modeled for them as children. Can naltrexone use still be considered for alcohol use disorder in a patient with elevated liver enzymes due to their alcohol use? This is another fantastic question. And this can be tricky because liver pathology is often part of the sequelae of alcohol use disorder. And it's important before starting naltrexone to get a baseline liver function test. I am a bit more hesitant if a patient has significantly elevated liver function test results. Often I will refer them to their primary care clinician or ideally a GI clinician to determine if it is safe. They may have to have a bit more hepatic workup They may need a liver ultrasound, but actually the number one cause of liver disease in the United States is fatty liver disease. And so we need to address not only alcohol use, but we need to address obesity, which is the main cause of liver disease. And if patients do have severe liver disease, naltrexone may not be the right treatment for them. Next question. I have experienced surgeons telling patients to stop methadone prior to surgery, or they will not receive pain medication. When we know that they would actually need higher doses of medication for pain control, how would you respond to this? Unfortunately, there's still quite a bit of stigma surrounding the use of methadone. And depending on the procedure, the surgery, yes, I completely agree with you. They should not be taken off of methadone. And it may be that the surgeon is getting methadone confused with buprenorphine. We know that with methadone, they can actually either increase their dose of methadone, or often what happens is they'll be put on an additional oral opioid medication for a brief time-limited course after their surgery. And I think it's important that we advocate for our patients and we provide literature to the surgeons that are unfortunately stating some factually incorrect information. I know me personally, there's so much about surgery that I don't know. And my hope is that the surgeons will be curious enough to read at least any reference articles that we can send to them about optimal pain management in the face of our patients using methadone. What are your thoughts on as-needed naltrexone, which they define as just taken before going to a wedding or somewhere they expect temptation to drink? This is a great question. This comes up a lot during my motivational interviewing with patients. I have patients with binge alcohol use disorder that do not want to be on a daily medication for their alcohol use, because their drinking they can predict and to a certain degree they can control. They don't have to drink every day. They don't choose to drink every day. But often when they drink, it can get out of control quickly for them, and they have difficulties regulating the number of drinks that they intake. And I've had many patients over the years actually deploy this method. And I found out, again, through motivational interviewing, and also I've had many patients over the years that it was essentially non-adherence, where they chose to not take it every day, but they found that it worked whenever they did choose to utilize alcohol, and it allowed them to moderate their alcohol use better. I've also had patients where they are in sobriety, they don't have cravings, but there's certain situations where they're triggered to drink. One great example is going on an airplane. I've had patients that struggle with flight phobia, and so they're always tempted to use alcohol on those flights. And they may just take naltrexone on those experiences, those occasions, while I also focus on treating their underlying anxiety simultaneously. This is not necessarily evidence-based, though. This is not how naltrexone was FDA approved. But if this is working for the patient in front of me, and it's a good harm reduction strategy for them, I'm always going to document that I recommended daily use. But again, if that's how they're choosing to use it, that is a safe way to use it. It's just they're likely going to have more relapses and likely have more alcohol intake than someone who's taking naltrexone on a daily basis. I wish I had more time. You guys ask such brilliant questions. I love the passion from the NEI community for treating patients with substance use disorders. I'm sad that this is all for today, and I hope these answers can help guide your work. And I wish you all the best with your patients. Keep doing the amazing things that you're doing. Our patients desperately need you, and I applaud you.
Hi there, I'm Dr. Lori Davis. Today I'll be answering your questions about my joint talk with Dr. Andy Cutler. Nightmares and Brainscapes, Emerging Therapeutic Avenues in the Treatment of PTSD. So let's dive in. How fast do you titrate up prazosin to 8 to 10 milligrams? I typically move it 1 milligram each appointment, which may be too slow. So that's a really good question. As I pointed out in the lecture, many people underdose the prazosin, trying to hover around 2-3 milligrams per night. and they don't go ahead and take it up to the 8 to 10 milligram, which is what was shown in the research studies to really be effective for nightmares and hyperreactive behavioral acting out or hyperadrenergic type sleep disturbances, waking up in a sweat, the bed sheets all tousled around, and having these very vivid acting out type nightmares. So we do want to keep moving up, having the patient be aware this is a weak antihypertensive medicine, so to check their blood pressure. And really, as they're tolerating it, they can move up every few days or once a week, go up from 2 to 3 to 4 and get up to 6 or 8 pretty quickly between your appointments. And I always have to look at the pill dose and see how I'm going to do that pill count, reassuring them that once they get to a higher dose, there's actually a higher milligram tablet, so they don't have to keep shelling out many pills in their palm at bedtime to get the same effect. So we work it up as tolerated and letting the patient know to check their blood pressure periodically. But it's a very weak antihypertensive, so it shouldn't cause that much of a blood pressure problem. Okay, here's another question. How does untreated attention deficit hyperactivity disorder play into improperly storing memories that lead to PTSD? That is a great question. We are doing a clinical trial right now with generic methylphenidate for the treatment of PTSD with neurocognitive complaints in the spectrum of attention deficit disorder. And the jury is still out. There's one small study that showed that methylphenidate really worked well, not just for the neurocognitive symptoms, but for the PTSD itself, for core symptoms of PTSD. So we are conducting that trial now in a much larger sample size, and it will probably be about a year before the readout for that study comes out. But what I'm hearing from patients who I think were responding to it is not only were their neurocognitive complaints helped, but their sense of sticking and staying in the here and now, not being as triggered by extraneous stimuli like they were before taking methylphenidate, was much better. And they could then tolerate public places, sporting events with their kids, that it had the ability to make them less easily distracted by extraneous noises that might trigger that fear response. So I do think there's an overlap here, and that PTSD itself could derail the whole attention, being able to focus and keep from being so easily distracted by extraneous triggers. Stay tuned for that, but stimulants might have a role in PTSD with neurocognitive complaints. That leads into why would that work? To have something that has really potent noradrenergic properties when we think about PTSD being hypernoradrenergic, and that might bring to this other person's question on how to explain the serotonin norepinephrine reuptake inhibitors. Why don't they worsen the sympathetic reactions in patients with PTSD? Why wouldn't methylphenidate worsen PTSD? So norepinephrine is a tricky neurotransmitter. PTSD is a very complex illness. So these neurotransmitters are not, all or nothing. And what I think is happening is there's a balance of norepinephrine that we don't fully understand. And it looks like that medications with some norepinephrine promoting activity is actually going to help patients with PTSD. Because a lot of this chronicity of PTSD is wearing out some of the neurotransmitters that keep us alert, focused, less easily distracted, and also the neurotransmitter norepinephrine helps balance impulsivity and emotional reactivity. So I think that one of the pharmacology plus the neuropathophysiology of norepinephrine systems is a balancing act. So I hope that answered your questions. That is a paradox in the treatment of PTSD. So I think that some of the neurobiology was more crudely discussed in our understanding of PTSD, so that when we get into these different pharmacologies, it doesn't always add up. But as you dig deeper into the norepinephrine system, you see that it's not an all or nothing concept. Okay, so digging down into some more of the complex questions here. I took the easier ones at the start, so we'll get to some questions that are more difficult for us to answer, and that is addressing a frequent question around the construct validity of complex PTSD and whether this is just a nicer label for borderline personality disorder. I've had that same question and that same thought. And so I would say that is something for the field to continue to study and debate. And it's really important that we get it right. I think both borderline personality disorder and PTSD have quite a lot of stigma attached to it. And there are different treatments that now seem to overlap with complex PTSD. Some of the treatments for borderline personality might have effects with complex PTSD, but really it may be that we are trying to evolve so that we can let go of a lot of the stigma related to borderline personality disorder and advance into an area that might be more recovery oriented, that patients might be able to grasp and better understand PTSD, to seek treatment, and to really exploit all the treatments for PTSD. Medication, psychotherapy, whole health approaches, mindfulness meditation, and of course, move away from more of a thought that once you have a personality disorder, it's hard to get rid of it and it's lifelong. So those are just some of my thoughts. Meanwhile, patients are suffering, and once we make the diagnosis, we want to go ahead and move forward with treating the person rather than the diagnosis. But good question. Another question here is the overlap of PTSD with bipolar type 2 disorders. And so trying to understand hypomania and whether or not we're putting patients at risk when we use the antidepressants, and what other choices might we think about. There's quite a lot of overlap with PTSD and bipolar disorder, mainly impulsivity, difficulty managing and regulating emotions. And some of the choices that we might think about is that might be the place to use some of these third-generation neuroleptics like brexpiprazole when we want to touch on treating PTSD without putting the patient at risk, and some of that bipolar quality could be more effectively treated with some of the mood stabilizers. What we do know from a lot of disappointing research is that the anticonvulsants as monotherapy did not look like they worked brilliantly for PTSD compared to placebo. And they do have a lot of different side effects that we would maybe want to avoid unless we know that is more effective. Lamotrigine being one of the exceptions, that it may have more ability to treat that mood instability as well as some of the symptoms of PTSD. And that leads to the next question then. How much impact can mitigating post-event exposure at or before memory consolidation with stress first aid or what other interventions might have, including pharmacology. So you're getting at the point of how can we prevent PTSD? And that is an enormous unmet need right there, is maybe dealing with emergency room or first responder or after a weather catastrophe. How can, in a war setting, how can we prevent PTSD? What can we do at that first call for getting help to people? And does debriefing really work? Or does that put the patient more at risk? And I think we're really still trying to understand that early phase memory consolidation. I think main thing we really want to do is get the person to safety, a lot of reassurance, allow the person who's experienced the trauma to lead the discussion, the need to tell the story. But if the person is being prompted to talk about their trauma, it could be opening it up for more difficulty consolidating the memory or eliciting more fear or anxiety. And I can just imagine in an emergency room scene from, some violent crime, the police are going to want to ask a lot of pointed questions. And how much is that putting the person more in a vulnerable state to develop PTSD? It looks like immediate post-trauma debriefing does not prevent PTSD. I don't know that we've seen that it makes it worse, but it's not a preventative measure like we would have maybe imagined. But some of that memory consolidation, pharmacologic approaches, it looks like maybe some early treatment there in the emergency room with the cortisol type treatments, steroids, or dexamethasone, be receiving for catastrophic trauma at that point can help with the PTSD, preventing PTSD. But that's all kind of looking at chart reviews and whatnot. So I think that those are great questions. I'm glad I had a chance to come and answer some of those that we didn't have time for on the podium. But that's all the time we have for now, and I hope this information is useful in your daily practice. Thank you.
Hello and welcome. My name is Dr. Leslie Citrome, and I'll be answering your questions about my joint presentation with Dr. Andy Cutler, Sex, Pudge, and Eyes That Close, Strategies to Address Common Psychotropic-Induced Tolerability Issues. So let's get started. The way I know non-adherence is when patients fill their 3-month prescriptions every 4 to 6 months, yet they say they take them every day. That's an important observation. I'm glad. Thank you, Larry Sanders, you suggesting this as something to consider, and I think that's really an excellent way of figuring things out when prescriptions aren't filled exactly at the times that you would think they would be filled. Next question here. What do you do if you order labs and the client does not have them done? Do you tell them you can no longer prescribe it or keep the medication on if effective and document that they were made aware of the risk? What do you do? Well, it depends on the medication. And a no-go would be, let's say you're prescribing clozapine and you have absolutely no information about the neutrophil count. Absolutely none. You need to have at least some. And there's some issues about lithium. If you dose it higher than what you would expect, a higher blood level, then you would need to do that. But low doses may be not. The other thing to do is make it easy for the person to get the labs done. Maybe it was a matter of the inconvenience of going somewhere to get it done. Maybe it could be done in the office. If you have any experience drawing blood yourself, this is something that I have done as well. Make it easier for them, and that may get you to where you need to go. And let's go on to the next questions. Can Zofran or Reglan be used with xanomeline trospium to treat the nausea? Well, you can try Zofran. You'll have, maybe it'll work for that individual person, maybe not, but certainly worth considering. Think, though, of the nausea as being essentially transient. And if it's not transient, then it may be an issue for that particular patient. Reglan, metoclopramide, I would not recommend under any circumstances for this because it is a dopamine D2 blocking agent associated with a substantial risk of tardive dyskinesia. If you read the product label for Reglan, it says don't take it for more than 12 weeks because of the risk of tardive dyskinesia. We don't have that same kind of warning for antipsychotics because that would not really work out because antipsychotics are taken indefinitely while the patient is experiencing, their schizophrenia. It's not going to go away. Okay, anticholinergic risk. There's a number of questions about this. And I was asked, how do I feel about benztropine? And what was I talking about there? Well, benztropine is something that we've been using for years when starting someone on an antipsychotic medication. In the old days, it was found that when you start it with haloperidol, the risk of drug-induced movement disorders is reduced, especially in those vulnerable to developing them like young men, and you would decrease the risk of acute dystonia in particular. But the research there really informed us that this would be done for about a week or so. But somehow we got into the habit of prescribing benztropine or trihexyphenidyl indefinitely. And that's a problem. Number one, it is an issue in terms of long-term exposure. You're going to increase the risk of tardive dyskinesia as well. So it was found that the use of benztropine is associated with an elevated risk of TD, not just exposure to the antipsychotic, exposure to benztropine. If someone already has TD, benztropine can make it worse. And that's actually the biggest concern I have with patients who are being treated for their tardive dyskinesia. If they're on benztropine or trihexyphenidyl, their TD would be worse, and this may mean that we're not really treating what we think we're treating. And when we slowly reduce the anticholinergic load over time, we may find that TD looks a bit different. And some patients really need an alteration of their dose of their treatment for their TD. So that's an issue. If you don't believe me that benztropine is associated with worsening of existing TD, read the label. It says, not for TD, can make TD worse. So it's a misconception that some people have that benztropine is a treatment to address tardive dyskinesia. It is not. The other thing about benztropine and other anticholinergics is that they can impair cognition. And our patients with schizophrenia, for example, already have impairment of their cognition. And we don't want to contribute to that. So all in all, I see no plus aspects regarding benztropine in today's era of second-generation antipsychotics. By the way, when I see people prescribing adjunctive benztropine to people taking a second-generation antipsychotic, I get pretty upset because it's really not necessary. If they do have drug-induced movement disorders on a second-generation antipsychotic, well, switch that antipsychotic to something that has a lower propensity for that. We have many different choices of second-generation antipsychotics, and some of them are completely devoid of any problems with drug-induced movement disorders. Okay, next question here was about quetiapine and its use as a sleep aid. So I'll make this statement again. I don't think it is a reasonable idea to prescribe an antipsychotic medication for sleep. Exposure to an antipsychotic means exposure to a dopamine receptor blocking agent. No matter how low the dose is, it does contribute to some degree to the risk of TD. So if you don't have to use an antipsychotic, I would not. We have such better treatments for problems with sleep that work in a way that is, I think, safer. So the dual orexin receptor antagonists really work well. So suvorexant, lemborexant, and daridorexant can be given chronically. They don't lead to tolerance. They don't lead to withdrawal when the medication is stopped. They don't interrupt the sleep architecture in a bad way. in fact, probably affects it in a good way. And so all in all, a much better choice. So I think the use of probably quetiapine is the culprit here. I do not recommend it. Well, that's all for the questions that you have for me. I hope to see you in person on the next occasion.
Hello, I'm Dr. Jeffrey Strawn, and I'll be addressing your questions about my joint presentation with Dr. Kari Franson, When Less is More, Strategies for Deprescribing Psychotropic Medications. So let's get started. Now, one of the questions that was well represented in the list of questions that came in was, how can pharmacogenetic testing play a role in deprescribing antidepressants or second-generation antipsychotics, perhaps in the context of MDD? Now, this question asks about pharmacogenetic testing, but what it really probably is getting at is differences in terms of medication metabolism. We know when we're talking about a number of the enzymes that metabolize psychotropic medications, for example, the cytochromes, CYP2D6, CYP2C19 being among the most common, there's a lot of variation in terms of how patients break down medications based on the activity of those enzymes. And so while we know that there's a lot of that variation that comes from pharmacogenetic factors, we also know that concomitant medications can also really influence that activity of those enzymes. So when we're thinking about discontinuing a medication, let's start with an example that maybe is classically known to go through one of these pathways. And I'll use citalopram or escitalopram, which is primarily metabolized via the CYP2C19 pathway. Now, we know that we can have some patients who are poor metabolizers and some who are ultra-rapid metabolizers. Now, if we have that individual who is a poor metabolizer of 2C19, and we're discontinuing citalopram or escitalopram, we may be able to get away with doing it a little bit more quickly because naturally the patient will have the medication lingering a bit longer. However, if we're dealing with a patient who is a CYP2C19 ultra-rapid metabolizer, we know that that's an individual who's going to clear the medicine markedly faster than will an individual who's a normal metabolizer. And so we may need to go a bit more slowly as we discontinue the medication. The other thing that's really important here is that when we're talking about some of the medications, perhaps that go through CYP2D6, like fluoxetine and paroxetine, we have a number of other factors that we really need to consider. So both fluoxetine and paroxetine will inhibit 2D6, although they'll do it in slightly different ways. The other thing that we remember with fluoxetine is that we're going to, even after stopping fluoxetine, still have inhibition of 2D6. So with fluoxetine, which is a strong 2D6 inhibitor, data actually suggests that it will render even normal metabolizers poor metabolizers, and we call that phenoconversion. So in short, it's PGX, but it's not really PGX. It's pharmacogenetics, but it's not really pharmacogenetics. It's variation in drug metabolizing enzymes that can either be genetically related or related to concomitant medications. All right, another great question came in that relates to one of the slides that I showed with an approach to tapering benzodiazepines. Now, the question asks, is switching to a long-acting benzodiazepine at 125% of the short-acting dose and tapering by 10% weekly better than the substitution method in the Ashton manual? Long-acting versus substitution is really probably a Coke versus Pepsi type of issue. It's ultimately about smoothing the curve. And one of the things that I think is really important is that when we're talking about longer acting agents, these allow for a gentler descent from whatever our prior dose is. Now, some patients absolutely do better with a long acting benzodiazepine because it reduces that rebound, crash, rebound roller coaster that we often see with the short-acting agents, including things like alprazolam. The Ashton method, as I look at it, probably is somewhat similar to what I'd proposed in the lecture. One of the things that I probably would mention is that my rationale for going to a longer-acting benzodiazepine at 125% was in those individuals who have actually failed an earlier slow discontinuation or dose reduction strategy. So again, the take-home message here is going slow, monitoring for rebound anxiety or withdrawal symptoms, and really allowing time for those GABA receptors to reset. The next question was, how long after complete resolution of catatonia before beginning a benzodiazepine taper? And for me, this is something where I would probably vary it quite a bit based on the individual. Again, we know that there are many causes of catatonia. We know that we see it in psychotic spectrum disorders. We know that we see it in a number of neurodevelopmental disorders, as well as other conditions. And so I think it probably depends on a number of clinical factors, but also in terms of that patient having had complete resolution of the catatonia symptoms and having been back to baseline. For me, this is a situation where I would generally want to see about 2 to 4 weeks of full resolution. I would again want to see no residual symptoms, no axiflexibility, no negativism, no autonomic symptoms, no motor slowing, if you will. And then most importantly, I think it's also important to consider those other factors, like making sure that the patient is in a stable psychosocial environment and that they're tolerating other medications that may have been introduced as well. Next question was, can you comment on deprescribing stimulants? And the answer is yes, I can. So stimulants are, because of their kinetics, a bit like switching on and off a spotlight, if you will. So suddenly the executive circuits step out of the light and you see what the brain can or can't do on its own. Now, this process happens very, very quickly. In fact, we can think about the fact that for many of our patients, they're actually discontinuing their stimulants every single day. Now, one of the things that we will sometimes notice is that there is return of either the core ADHD symptoms, as well as what we might call executive fatigue. So some of those symptoms that are obliquely related to ADHD, but maybe have a different flavor. So that extreme difficulty with task initiation, or just feeling a slower processing, or even perhaps some of that emotional dysregulation. Now, the other thing that probably is important to remember when we're talking about the stimulants is that we're often using them for conditions other than ADHD. We may be using them in treatment-resistant depression or difficult to treat depression, as some have recently advocated calling it. We also do use them in chronic fatigue syndrome. We also do use them in a number of other conditions. And I think it's really important to consider the indication for which the stimulant was actually started. Now, when I'm looking at patients with ADHD, again, I don't necessarily taper. However, if the stimulant was used for another condition, including some of those that are associated with chronic fatigue, I may taper it. And that taper is not necessarily because I'm worried about withdrawal symptoms. It's more wanting to ensure that I'm not seeing recrudescence of the underlying disorder. Now, certainly in a situation where I'm considering stopping a stimulant or stimulant type medication and moving to another stimulant or stimulant type medication, a direct switch is absolutely, certainly very reasonable. The next question was, what is the incidence of severe complications in benzodiazepine withdrawal? Now, when we're thinking about benzodiazepine withdrawal, and we're thinking specifically about severe complications, and by that I mean seizures, delirium, autonomic instability, these are certainly uncommon, but I think it's important to remember two aspects. One is that with proper tapering and monitoring, that risk is certainly well under 1%. But I think the second part is knowing that there are things that we can use to predict who may be at higher or lower risk for these severe complications. We certainly know that individuals are treated with higher doses of benzodiazepines or short-acting benzodiazepines, as well as those in whom are tapering more rapidly, are at higher risk of withdrawal and of more severe withdrawal symptoms. We also know that some other factors may also increase that risk, and these include things like co-occurring substance use, particularly with other medications that may affect seizure threshold, individuals with epilepsy or seizure disorders, and also those with myriad comorbid medical conditions. So I think really for me, the take-home rule is assume every patient has the potential for withdrawal and aim for prevention, not rescue here. The next question was about the deprescribing schedule for venlafaxine. And venlafaxine is really the poster child medication for the brain knowing when you miss even a single dose of the medication. Now, another thing that I think is really important to consider when we're thinking about venlafaxine is that it is not necessarily the same medication, say 37.5 milligrams of extended release versus at 150 or 225 milligrams a day of extended release. And a couple of things we know. One is that as you get to higher and higher doses, you tend to have more noradrenergic effects. Now, in some of the literature, people will refer to doses greater than 150 milligrams as being associated with that higher risk of noradrenergic blockade or blockade of the norepinephrine transporter. However, one of the things that we also know is that not everyone's the same. That's right. You heard it here first. Not all patients are the same. And what am I talking about? I'm talking about cytochrome 2D as in dog 6. And we know that venlafaxine is primarily metabolized by a 2D6. And so what happens is that we have some individuals who are metabolizers of 2D6. Now they're actually going to have more venlafaxine relative to the metabolite desvenlafaxine. That's important because venlafaxine has more serotonergic effects, whereas desvenlafaxine has more noradrenergic effects. So not only do we need to consider the dose, we also need to consider how venlafaxine has essentially been converted to its active metabolite or not been converted to its active metabolite in any given patient. Now, to the actual question at hand, what is the deprescribing schedule for venlafaxine? I think really the important part to remember about the deprescribing schedule here is that we really need to go slow. And probably as we move to lower and lower doses, we actually need to slow down a bit more. The other thing that I think is important is that as we're discontinuing the medication, if we start to run into those withdrawal symptoms, we certainly need to return to the last tolerated dose. And then at that point, I might start slowing my titration even more, perhaps decreasing by 10% decrements, if you will. The next question was, is there any sleep aid that helps with cannabis withdrawal? And boy, I wish my friend Kari Franson were here, as she really is the world's expert on cannabis and cannabis pharmacokinetics. However, what I will say is that cannabis withdrawal is quite complex given its interactions with numerous components of the endocannabinoid system. So sleep often is disrupted. There are certainly a few things that can help. We could use things like gabapentin. We could certainly use things like hydroxyzine. But there are a number of other things that we can use, including things like melatonin, and even including things like chamomile tea, which has a compound in it which does interact with the GABA receptor. So again, it's not just about that ritual of having the chamomile tea, but also about its actual psychopharmacology. The next question was, if a patient has residual symptoms because they're struggling to adjust to having a medication, I'll use their term, taken away, is motivational interviewing or CBT more appropriate? Now, one of the things that I think is very helpful to think about is what are the psychological processes that are actually giving rise to that difficulty with having the medicine, quote unquote, taken away. And as we talked about in the presentation, there can often be ambivalence, there can be fear, there can be issues related to loss of identity. In other words, the patient may be thinking this medication kept me stable. Who am I without the medication? And I think certainly motivational interviewing, as well as other types of CBT-based interventions, can actually be very, very helpful here. Now, if the issue is skills, in other words, managing, or as I often talk about, tolerating that distress that comes with anxiety, then I think CBT is definitely the way to go. Again, I want to thank everyone who was able to join us in Colorado Springs for the NEI Fall Congress, and also encourage you to listen to other episodes of the NEI Psychopharmacology podcast. It's been great answering your questions, and I look forward to our next time together.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.